Okay, morning everybody. You're very welcome. My name is Steve Thompson. I work with Charity Entrepreneurship and Training for Good, and I'm going to be hosting this session this morning, so you're very welcome. Well done for getting in on the early session. Fair play. Traditionally, EA has, particularly Neartermist EA, has focused on quite a narrow range of interventions and evaluating causes solely on physical health and economics. And perhaps this is limiting us, and perhaps there's a lot of opportunities beyond that. And that's what this talk is going to primarily be about. You can ask questions through the Swap Card app, and I'd like you all now just to stand up for a moment. We're going to do something very non-EA for 30 seconds. Put your hands down by your sides, feet shoulder width apart. I'm super nervous doing this, I don't know why. Cross your arms. Okay, how does it feel? You can shout out, right? So just how does it feel? Jack, how does it feel when you've got your arms crossed like that? I wouldn't have expected such a response from you. Anybody else got any different feelings maybe? How does it feel? Protected? Yeah. A little powerful? Yeah. Familiar maybe? Bit safe? Protected? Yeah? Okay. Angry? Okay. Ooh, okay. Okay. Drop your hands down by your sides. Okay. Now do it again, but this time do it the other way. How does that feel? Weird. Yeah. A little uncomfortable, a bit unfamiliar. Okay, that's it. Have a seat. What the hell was all that about? So, when something's familiar, we just lock into it. We go into always the same way. That's all fine. There's no resistance. But trying to get ourselves to do something that's different, like anatomically, biologically, there's no benefit to going right over left or left over right. But one feels good and one doesn't feel good, right? So maybe because we locked into some of these ways of thinking about near-termism early on, they feel familiar and they feel good, and trying to change out of those is just going to create a bit of resistance. That resistance may not be a good indicator that we shouldn't change out of them. Make sense? Okay. So I'm going to introduce our two speakers, and then we're going to have a bit of Q&A. And as I say, you can use the Swap Card app. So originally from the US, Joy Bittner has been living and working in Latin America for 15 years. Last year, she launched through the Charity Entrepreneurship incubation program, nice plug, her charity Vida Plena. And it's using evidence and data to tackle depression at scale. And next year, they expect to treat for depression about 6,000 participants. So their model appears very, very cost-effective and very scalable. So we're really, really excited about that. As well, we have Ben. Ben co-founded the Maternal Health Initiative, along with Sarah, who's here as well. And it's an evidence-based org that trains health workers on effective family planning counseling. Okay? Again, it looks very scalable, and it looks very, very cost-effective as well. Ben studied international development in Edinburgh and has previously founded an EA org called Effective Self-Help. Okay, so I'm going to ask Joy to come up and talk to you about her charity and how we might be able to expand beyond the original near-termist kind of thinking zones.
Great. Oh, sorry. Oh, sorry. Thanks. I have to say I am exceptionally impressed that so many people have shown up Sunday morning, which is undoubtedly the worst time slot in the conference, to a talk titled Near-Termism. Really been quite pleased to see that. If there wasn't like a controversy, like secret plot to bury near-termism, here we are. And so, but anyways, thank you so much for coming out. Like as Steve said, my name is Joy, and I am the creator and co-founder of the mental health charity Vida Plena. And I am also aware of the irony that my name is Joy, and I started a mental health charity. So I just want to say thank you to my mom for not naming me Chastity, because who knows where we'd be then. So yeah, so Vida Plena, we are based in Quito, Ecuador, and it means in Spanish, a flourishing life. And so what we do is we provide evidence-based depression treatment for people who are either low income or refugees, basically people who otherwise would have no access to care. And we do that through a model of intervention that is cost effective and highly scalable. So Really proud to say that we are the first organization from Latin America to go through the CE program, and actually one of the very few, almost only organizations in EA working in Latin America. So to kind of get started off today, I'm going to take like a cue from and ask you to pick only one: health, wealth, or happiness. So most people pretty quickly realize that wealth is not the correct answer. Health even as well has its drawbacks. And so philosophers such as Michael would say that that's because these things are instrumental values. They help us to get to the things that we more intrinsically value. And so kind of framing that in part of like the bigger conversation of where we're going. So GiveWell has done a good job of setting a baseline of thinking about how do we improve things in terms of increases in wealth and in income? How do we make specific incremental changes in specific areas of health? But I think most of us, as we think of our own lives, we realize that those are not the only things that we're seeking after. We actually have something deeper, a little bit more. So there's other things that we're looking at, and you could kind of sum that up with the concept of well-being. It encapsulates lots of aspects of our lives. It's looking at our family, our relationships, our connectedness, our personal agency, our ability to achieve the things that we want to achieve. And so one of the problems that comes up with DALY's disability lived life years that GiveWell is using to be able to measure how they look at health is the way some of the back end of the way DALYs are created is what they did is they went out and they asked people, how would you feel, how do you think you would feel if this thing happened to you? And people give their best guess. Fortunately, what they didn't do is they didn't go up to people who are actually living with that condition and ask them, how did they feel about their lives? And the problem with that is that people were not very good at predicting how other people feel. And so what that means is we end up overweighting some things and underweighting others. So there's another metric I'll propose we could think about using, which is the well-being adjusted life year. And what that uses is subjective well-being. This will be a term that's familiar to some of you, probably many of you. But really what that is asking people directly, how do you feel about your own life? Are you satisfied with your life? Are you happy? And the value of using different types of metrics is that it helps us to identify things which would be otherwise overlooked and not considered. So I'm going to really be making the case today for considering global mental health as a cause area within EA. Just like as a side note, when I talk about global mental health, that's a term used by people in the field to describe mental health in low and middle income countries, such as Ecuador, rather than there's a lot of great initiatives that are happening for mental health internally for the community within EA, but global mental health is happening other places. So I'm going to talk to you a little bit about like why you, as very thoughtful EAs, should be thinking and caring about mental health and depression. I'm going to talk to you about some of a specific intervention that we're using with Vida Plena and the model of how that works. And then finally, really want to get you excited about what the future can look like. So stepping back for a second, so why should EAs care about mental health, global mental health, specifically neglectedness? When I started to like look into this a little bit more, some of the numbers are truly shocking, and they just really make you step back. So throw some figures at you. I'm going to be focusing on Latin America because that is where I'm focused and working. But according to the World Health Organization, about 5% of people living in Latin America have depression. So that's not quite right because those numbers are pre-pandemic, and some people expect that it went up even 25%. But let's try to like bring that into numbers. And so if you take the population of Latin America and we stick with that 5% number, what that means is there's about 33 million people right now living with depression. But even that doesn't catch the full experience, because if you've had anyone in your life who's gone through a period of mental illness, it doesn't just affect that one person, because we don't live lives that are individual. We live lives that are part of communities, that are part of families. And so that means there are several hundred million people who are being affected by depression right now. People's parents, their siblings, their partners, their kids. So Also, I want to step back. Also, some of you are probably wondering, so 5%, how does that compare to, say, the US? And it's about on par. In general, depression levels are similar in the US, Latin America. And so I wanted to dispel two specific myths that, as a result, often come up. The first is that's like our modern life and all the stresses that we're facing, that's what causes depression. And so depression is just a problem in developed countries. That's not true. There's a lot of factors that play into depression. Some of it's genetic, a lot of it has to do with life circumstances, financial press, relationship problems. Those things are things that are experienced by everybody. And on the flip side, I often hear that like, well, if we could just solve poverty, then that would also fix, we wouldn't have mental health problems, and that's the reason people, okay, we obviously know that's not true because that would say that there's no depression and no mental health illness in the US, which obviously is not correct. So really what I'm saying here is that depression is a universally lived experience that everyone faces. This happens to people everywhere around the globe. So while facts and figures can be a really helpful shorthand to try to summarize the experience of people, I know that people in this room have also lived through a period of depression or mental illness, or you've watched somebody very close to you go through that. So you already know why this matters. Depression to define depression, it's the first characteristic to be as classified high depression is having an abject sense of hopelessness. The second is that you're unable to enjoy everyday life. Normal things have normal pleasures. So really what we're talking about here is a lot more than just sadness. It's the type of feeling that takes over your entire life. It means the things that you want to do start to feel exceptionally hard, maybe even impossible. You can't get out of bed. That your life stops feeling like it's worth living. And often worse is that sense of terror that it might not ever get better. So we put this label, we say like mental health, as if we could put it in a category, just put in a bucket, and it only affects our emotions, and it's just like this one little thing. But the reality is mental health affects every single aspect of your life. It affects your physical health, it affects your work, it affects your relationships, it affects your families. And so as EAs, kind of our big mission, our calling, if you will, is to end suffering. There is mental health, mental illness is it is an extreme form of suffering. So much so that people who are living with severe depression are 20 times more likely to die from suicide. However, there is good news. We do have interventions that are evidence-based and proven to help people come out of depression. Specifically, I'm going to talk to you about a type of therapy called interpersonal therapy. And that therapy is part of, for people who are familiar, it's part of the third wave, kind of after CBT, considered to be one of the gold star evidence-based therapies. And this therapy has been adapted by the Columbia University Global Mental Health Lab to be used in low and middle income countries, such as Ecuador and Latin America. And the WHO endorses it as being the first line of treatment in low income settings. This is a highly evidence-based treatment. Like I said, it's considered to be one of the top treatments for depression. And this specific intervention has been tested all the way going back to 2003, in which a team of researchers in Uganda did a randomized control study. And they found that compared to the control group, 75% of participants had an absolute reduction in their depression symptoms 6 months following the end of treatment. So what that's saying is this not only works, this actually has a long-lasting impact on people's health. So that's like exceptionally great news as we start to think about some of these world problems. So then going forward, Columbia University over the past 15 years has been applying this. They've been working with some of the biggest names in international development. They work with USAID, they've worked with CARE, they've worked with the entire Ministry of Lebanon to implement this across Lebanon. So there's a number of different organizations that are using this throughout sub-Saharan Africa and the Middle East. We have a tremendous body of evidence demonstrating that this does work. So that brings the question, how does it work? The way it works is it's a group of people coming together. This is a group therapy, about 7 people, and they meet in their local communities, in the local community center, in their church, in the health clinic, basically the places and spaces where people already are. And the therapy itself is based off of helping people to understand the interplay between their depression and their depression symptoms and their daily life and their relationships, and then how their daily life and relationships affect their depression and symptoms. Then it helps people to understand how they can apply different techniques and practices to better be able to control their depression, all while doing that in the group setting, so they're building a stronger network of people. What it really comes down to, though, if you go back to that original, one of the defining characteristics of depression is that lack of hopelessness. It is helping people to have a renewed sense of hope, helping people to realize that depression is not something that you are 100% just a victim of that'll happen to you, but you actually can take some control back and you can learn how to manage it. And that is why there is that long-term impact, because what we're doing is not just helping people in the moment, but we're helping them to learn new skills so that when inevitably there is another crisis that comes up, they are able to have the ability to make sure that to mitigate it, so that way it doesn't become something that so completely takes over their life. So also another really key aspect of this is you might imagine, okay, to have such results, we must be working with a team of very expensive psychiatrists, psychologists, and one of the most exciting parts of this whole therapy model is that what we're doing is we're actually working with local communities and training local community members to be able to facilitate and run these groups. So that is what makes it kind of like really a different sort of model. And so what those facilitators are doing during the group conversation is they're helping to guide the conversations, they're helping to ask the probing questions, and kind of not unlike your most emotionally intelligent, thoughtful friend might do. They kind of help dig into that problem, like, okay, you had that fight with your husband, like, what did you exactly say? Or you need to have this difficult conversation with your boss, let's like practice that. And so kind of like what that really thoughtful friend, and so what really though is happening is that means that it's not a difficult therapy to apply in these contexts, and it's possible for somebody without having gone through 6-10 years of training to be able to apply. And so what that leads me to is the next point, that this is exceptionally cost-effective. We did a predictive cost-effective analysis in which we expect that operating at scale, Vida Plena will be able to provide treatment for $77 per person. And if you remember going back to Wellbe's, that comes to about $17 per Wellbe, which, okay, out of context doesn't mean a lot. So if you're looking at comparing it to direct cash transfers, in terms of improving subjective well-being, we expect to be 8 times better than Give Directly. So kind of like going to my story and kind of where we got started. So I had been reading about this extensive body of evidence, was really what really excited me about what they're doing, but then I realized nobody was doing this in Latin America. So kind of to like step back, I'm obviously from the US, from my accent, but I've been living and working in Ecuador specifically because I was very excited about the idea of economic empowerment. I wanted to help people, and I wanted to end poverty. So I went to work for a fair trade company, and we were working with a group of indigenous women who made handmade jewelry. Idea to give them better incomes and jobs. And because of that, I spent a lot of time sitting around tables, stringing beads with people, and these women, and really got to hear a lot of their stories and what was going on in their day-to-day lives. And there was one woman, I'll call her Maria for now, she had lost her husband to suicide, leaving her the single mom of 4 kids. And we had hoped that giving her this job would solve their problems. And of course, you might imagine it didn't. And so I was trying really hard kind of to connect her. I was like, okay, we need to get you in to see a psychologist. You and your kids, you need to see this. This is what needs to happen. And I tried to make all the phone calls, and I tried to work all of my network and connections. But we're in this little rural village, and because of the distances and the costs and just all of the logistics, I couldn't do it. I failed. And so that's kind of was one of the pieces that really kind of helped me to see we need to be thinking beyond just income generation. And so from there is what caused me to want to start Vida Plena. So kind of where we are today. So last year we went through the Charity Entrepreneurship incubator. And I say we because my co-founder is Anita Caslin, who is an Ecuadorian clinical psychologist. And so we partnered with Columbia University, literally the same individuals who have done all this training. They trained our team in Ecuador, and we ran a pilot this past fall. We trained 16 people and ran 10 different support groups. And just this past week, we finally finished tabulating our end-line results. And it was one of those moments that was like, I had read all of the studies, I thought this was possible, but you're not quite sure. And so a lot of nail biting. And so thanks to someone, a volunteer through EA helped us tabulate, we had an average of a 6-point drop in depression scores. So what that actually means is people started out the program with moderately severe depression, and they ended on average with no to minimal depression. So this is just as like a caveat, like this is only pre-post study. We'll be following up in 3 months to kind of like check in and see if this is actually lasts. As a pilot, we didn't have a control group because we were really just focused on, is this feasible? Can we adapt it? Over the course, by the end of next year, we do want to run a second study, including that control group. But really what this is actually saying is like, it's pointing the right direction. Things are working, we're moving the right way we hope to. And as part of this, I want to take a moment and actually give a huge thank you to all the people who had been part of this and supporting us. Obviously, the incredible team that we're working with in Ecuador and all of their hard work. But right here in this room, I also want to say thank you because I know in EA, this is a difficult moment. There's a lot of like strong, like dark things that are happening and a lot of like really hard feelings. We're passing through a hard time. And I feel that, but I also really want to kind of point out and say, it is absolutely thank you to the EA community that this program can exist. I started Vida Plena and I had this idea literally a year ago. It was just this idea on digital paper, but there wasn't a single person, there wasn't a team member, there wasn't any groups, I didn't have any money. And it is literally thank you to EA. People in the EA community who I met at an after party at AUG who were like, yes, I'm gonna give you some money towards this. Then the CE program who said, yes, we believe in this. Volunteers from EA who have given their hours to tabulate the numbers, to cut together that cost-effective study, who've given me endless hours of guidance and support. It's not an exaggeration to say that I would have burned through my personal savings and this program would have died without EA. And so like EA at the end of the day, it's like this incredible belief that we should do something to help the world, and then this crazy optimism that it's actually possible. And that is like the foundation of what EA is. And so that is why it is just thank you to every single person in this room who is part of that crazy belief that we actually can do something. So kind of like stepping back to like where we're going from here. So our goal is in the next year as Vida Plena to kind of solidify our program and our program model. And we plan to be able to treat 2,500 people. And then next year, treat 6,000 people, and over the course of 5 years, start to expand throughout the region in Latin America. So these are obviously very ambitious scaling goals, and you might think like, okay, how is that possible? First thing is we are adapting an existing program, which gives us a great leg up. And then the second thing is we can train one facilitator for just about under $200. And that person receives an annual salary about $9,000, which in Ecuador is a decent local salary. And that person, over the course of a year, can run about 60 groups. And so if average has 7 people per group, that means about 400 people annually. Our goal is by the end of next year to have at least 50 facilitators. So that's kind of like our short-term sort of vision of how we'd be able to scale. But what I want to do is I want to talk to you about like bigger ideas and where we're really going with this. So if we zoom out and we remember there's that 33 million people right now in Latin America who are living with depression, if we take that on average cost of $77 to treat someone, that means over the course of a decade, if we had an annual budget of $250 million, we could do that. We could reach every single person. So obviously, $250 million annually is a pretty high budget. That is a big number. But I just want to put out counterfactually, UNICEF just last year released a report in which they estimate that untreated mental health illness in Latin America costs 30 billion. And so all of a sudden that 250 million compared to 30 billion is not such a bad, the counterfactually, it makes a lot of sense. I'm not saying that Vida Plena or like the nonprofit sector is actually gonna be that. I don't think that's the pathway. But what actually is the pathway to be able to achieve this type of result is that right now in Latin America, on average, national governments spend about 1% to 2% of their public health budget on mental health. In Ecuador, it's even less. It's just 0.4% of their health budget is spent on mental health. So if we're able to tip those numbers in just a little bit and through government partnerships, then this is actually achievable. In the next 10 years, we can provide evidence-based depression treatment for everybody who needs it. And the reason I want to do that is because I don't think that people, because 3 out of 4 people in Latin America don't have any access to mental health care. And just because of where you're born, that shouldn't be the barrier. It feels dramatically unfair because you're born in a certain place, you can't get the care you need. So where are we at now? Just to kind of like sum it up, obviously there's a need to scale up critically, quickly, and rapidly. And so to do that, we need for EA, for everybody here to be part of that mission. Vida Plena isn't the only organization who's working on global mental health. There's also Kaya Guide, Strong Minds around the world. There's Friendship Bench. And there's actually the Mental Health Funding Circle, which is an EA circle of people who are committed to donating to this cause. And so getting involved in those spaces is what it'll take to achieve that goal within a decade, treating everybody. So just to kind of sum it up and kind of close where we're at is mental health is foundation of well-being. So EAs, we need to care about this. This is an issue that is neglected, tractable, and highly cost-effective. There is the possibility we know how to solve this. And so now is the time to do that. Thank you very much.
Great stuff. I'm going to hand over to Ben. Give him a round of applause.
Yeah, I would like to talk today about the organization that I run, the Maternal Health Initiative. So we're all here to do the most good. That's the central premise of effective altruism and what brings us all here this morning to this room from all our various corners of the world, perhaps a little early on a Sunday morning for some of us. But what does it mean to do the most good? And should we be so sure that the interventions we celebrate truly are those that improve people's lives the most? I want to convince you this morning that conventional ways of evaluating interventions may be missing out on some of the most powerful ways of doing good. Doing the most good to me means doing things that bring the greatest improvement to people's lives as a whole. This means more than just health and income. As Joy has just wonderfully described, efforts to measure well-being directly are a great example of this kind of work. I want to build on this through the work of my organization and Sarah's organization, the Maternal Health Initiative. And we improve access to contraception in sub-Saharan Africa. And now we hope this work can bring transformative benefits to people's agency, to their fundamental ability to shape their lives in the ways that they want, alongside more conventional, though no less valuable impacts, reducing maternal and child mortality. So to ask a simple question, how do you value the ability to choose if and when you have children? It's a simple question that captures a complex set of possibilities. Or perhaps we lack the kind of robust 5 or 10-year plan for our lives to maximize their value that we might expect of a major charity or business. I'd argue that we all have some level of a vision for how we would like our lives to play out. On a gut level, the choice of if and when to have children feels like one of the most fundamental shaping factors in how that vision is realized. Crying children at 4 a.m. make it somewhat more difficult to see that sunrise on the beaches of Vietnam, or to finally adopt that morning routine of an ice bath while drinking hand-ground coffee and meditating on existential risk that is the mandatory practice of every EA organization leader. In other words, control over your fertility is about more than just whether pregnancy might affect your health or having a child would mean an extra mouth to feed at night. It's about the vision for your life you hold and your ability to realize it. It's to control a decision that fundamentally changes the rest of your life. For many of the women we work to reach, this is more... One second. For many of the women we work to reach, this question of how to value the control of having children, of what they make sacrifice to realize that choice, is far from hypothetical. For them, it is a question with significant, painful trade-offs. Would you sacrifice your family's meal that day? Would you risk ostracism from your community, an argument, or worse, from your partner? Would you accept getting fat, becoming infertile, or any of the other wild rumors you've heard about using contraception? Our mission at the Maternal Health Initiative is to make sure people don't have to make these kinds of trades. Our work ensures that women can receive high-quality, confidential contraceptive access and information at a convenient time and location, so that they don't have to pay for transport to another town a few hours away, so they don't have to risk community judgment and gossip buying contraception at their local pharmacy, and so they are no longer influenced by a raft of wild myths and misconceptions around accessing family planning. This work produces reductions in maternal and infant mortality competitive with top recommended charities, with a cost per disability-adjusted life year of just $166. What I want to convince you of today, however, is that the value of the work is so much more than this, that providing the women we reach with this control over their fertility, with the ability to shape their lives, and the peace of mind in knowing this is a potentially transformative good. Providing autonomy to these women is more than just a bonus to saving lives, but fundamentally valuable in and of itself, valuable enough to be critical in any fair evaluation of the effectiveness of this work. The most significant good that we can do isn't limited to health or income. It's about the opportunities we provide to people to live happy, flourishing, meaningful lives. Doing the most good is about more than saving lives or putting money in people's pockets. It's about making people's lives as good as they can be, in exactly the same way that we want more than just decent health and income for ourselves or for those close to us. These are difficult things to measure, and I don't have the answers today of how precisely to value them. But that shouldn't be stopping us trying to find them. The EA project is about doing the most good. We shouldn't settle at the point where things get difficult to measure. The importance of providing people with agency is not a new idea in global development. One of the most well-known framings of this is the capabilities approach, championed by two leading development scholars, Amartya Sen and Martha Nussbaum. In rough terms, the capabilities approach argues that what people are functionally able to do with their lives in practice, what things they can choose to do and to avoid, is the determining factor in the quality of their lives. From this view, having good health or sufficient income are just a couple among many capabilities that constitute a good life. Our goal as development practitioners, as people who care about the world, should be to maximize the capabilities that people have with their lives, maximizing the choices that are available for them. By prioritizing autonomy and opportunity, we allow for people to choose for themselves what they value and what kind of life they want to live. And this is more than just a nice academic theory. It's fundamental to the views of the people we talk to and the people we work with. Just a couple of weeks ago, I was lucky enough to be discussing this with two women leading health work in Tamale, the main city in northern Ghana, where the lush tropical belt of sub-Saharan Africa begins to meet the dusty Sahel region that blends out of the Sahara Desert. For Effia, one of the women I spoke to, contraception presents an opportunity to express her right to choose and a fundamental level of control over her health. Her 3 children are a gift, she told me. Using contraception allows her to ensure that an unintended pregnancy can't jeopardize her health and her ability to provide for those very children that she loves. This access is about more than just providing control, but also preserving opportunity. Contraceptive use is a lever of opportunity, the kind of small, seemingly insignificant action in someone's life that fundamentally shifts the opportunities in front of them. In Sierra Leone, the midwives and clinicians we've worked with often speak to particular sadness of teenage girls who lack access to family planning due to the difficulties for them to obtain it in privacy. On the outskirts of the university town of Bo, we spoke to midwives at Haikel, an NGO-run clinic with parched fields of grass on one side and a local high school on the other. And these midwives described the frequency of girls in the latter years of attending that very high school who would come in pregnant. As soon as that pregnancy is there, they explained, that's the end of any possibility for further education for that girl. Education is about more than higher earnings. It provides each individual with a permanently greater set of opportunities and a permanently greater breadth of potential, with benefits flowing through to their communities and the country that surrounds them. Impacts like these on the opportunities and potential of individuals seem fundamental to the good that any intervention may provide. The problem is, As it stands, we have no good way of incorporating these effects into the kinds of models and cost-effectiveness analyses we like to use to evaluate and compare interventions. There is no neat autonomy-adjusted life years, or at least not yet. But we can quantify the cost of the agency benefits that a given intervention provides. Through MHI's work, our work, we estimate it will cost just $4 to provide a woman with contraceptive counseling, encompassing both providing accurate information from a trusted source and the opportunity to receive family planning right there and then if she so chooses. Though we don't have units of agency, the transformative potential of family planning makes $4 look a bargain to me for a fundamentally improved control of one's life. Alternatively, we can use proxy metrics for agency that are somewhat easier to measure, such as surveying women on their level of decision-making input, freedom of movement, or choice over their behaviors across different domains. Which proxy metrics best indicate control over one's life can easily be debated, and the use of proxy metrics can often fail to capture the broader implications of a concept like someone's control over their life. Clearly, there are challenges here, but by not including these effects, we're almost certainly leaving impact on the table in our analyses of different work. By not considering impacts like agency or well-being as core effects, rather than bonus benefits, we may be prioritizing the wrong areas. Put a little dramatically, we may be failing far more significantly in our mission to do the most good than we realize, and crucially, failing more than is necessary. We believe our work on access to contraception provides a fantastic example of this. It's competitive with top charities purely on health effects. What gets us truly excited about this work, though, is the potential that is transformatively good when its full range of impacts are considered. By focusing on only one or two metrics, two interventions may appear similarly impactful, when in fact there is an order of magnitude difference in their outcomes. In evaluating our work, we want to find out whether this is true for family planning and just how large this difference may be. So what exactly do we do? The Maternal Health Initiative is an evidence-based nonprofit dedicated to improving the lives of women and children across the world by training healthcare workers to provide high-quality family planning counseling. 218 million women in lower-income countries have an unmet need for family planning, resulting in more than 85 million unintended pregnancies in 2019 alone. The scale of these numbers would be breathtaking, were the consequences not so sad. More than 1/3 of these unintended pregnancies in sub-Saharan Africa end in abortion, an unsafe abortion, often outside of a healthcare facility in countries where abortions are dangerous and heavily stigmatized, if not illegal. That so many women still choose this path is a sorry indictment of the lack of agency they have over their reproductive lives at prior points, demonstrating both the high value these women place on their ability to control their own autonomy and their lack of opportunity to express this control in ways that do not risk their health and well-being. The Maternal Health Initiative is here to change this, ensuring every woman has control over when she may get pregnant. To achieve this, we provide training to health workers in low-resource contexts to support them in maximizing the effectiveness of the family planning counseling provision that they offer. Our training program is light touch, but targeted at key bottlenecks in women's access to contraception. We provide midwives and clinicians with concise knowledge of different methods, including their benefits, side effects, and then we give them a framework for discussing contraception in a way that provides women with genuine opportunity to ask questions and explore different methods. Specifically, our training focuses on the provision of counseling in the antenatal and postpartum periods. That's the periods before and after a woman gives birth. Several randomized control trials have demonstrated the effectiveness of increased quality of care during this period, with antenatal and postnatal care providing a unique opportunity for improving access. Women are already visiting facilities and receiving care around their pregnancy. Our program integrates family planning counseling into this care so that women can obtain contraception confidentially and at no additional cost. No trips to the pharmacy, no choice between going to the market to sell goods or traveling hours to visit a clinic away from their community to protect their anonymity. High-quality information integrated into a convenient touchpoint, offered in private from a source that they can trust. Targeting the postpartum period has further benefits because of the risks of short birth spacing. Put simply, a woman's health and nutrition need adequate time to recover following a birth before an additional pregnancy. This is not a crazy idea. And a synthesis of the literature evaluating the impact of pregnancies that occur within 2 years of each other suggests an 18% higher risk of infant mortality and 16% higher risk of maternal mortality. Despite this, contraceptive counseling around pregnancy and after particularly rarely takes place currently, with healthcare workers and women they serve often unaware of the severity of these risks. And this is understandable. Many health workers receive little formal training around family planning, leaving them powerless to provide this sort of information, and more broadly, powerless to combat some of the common myths and misconceptions people have around the use of different methods. Simple but harmful myths, such as that a contraceptive implant might travel through the body and affect the brain and change people's personalities, are easily dispelled when health workers are confident in the knowledge of how these methods work, or simply have a model of the method to show these women so that they can understand what is involved. In this way, our work delivers autonomy, not just through the direct increase in access to family planning commodities, but also ensuring women have genuine access to information and high-quality, accurate information, understanding both the benefits and side effects or drawbacks that they might experience. Without that information, there is no possibility of an informed choice. Without that, there is no possibility for women to fully realize their preferences around such a fundamental part of their lives. For less than $4 per person, we estimate that we can provide this kind of high-quality, informed choice to more than 1 million women in the next 5 years. For $4, we can provide each woman with full agency over her fertility, giving her the opportunity to delay her pregnancy after a tough harvest, the opportunity to continue education or employment instead of caring for an unplanned child, and at the very least, the peace of mind, the dignity that comes from controlling her own fertility. In the 6 months since launching, we've been hard at work laying the groundwork for a highly scalable, cost-effective program providing this service. We've engaged more than 30 experts in the design of our intervention and spoken to a few dozen stakeholders across the 2 countries, Sierra Leone and Ghana, that we are currently doing provisional work in to test the most impactful location to scale our program. In the next 3 months, we'll run a full pilot of our intervention, measuring its effectiveness in providing informed choice and the far-reaching benefits of contraceptive access. With promising results, we plan to scale this intervention and have begun preliminary discussions with the relevant national departments in both Sierra Leone and Ghana around the potential long-term integration of our training program into national training guidelines and curriculums. We believe that over the next 5 years, we can transform the quality of care women are receiving across sub-Saharan Africa through light touch training that maximizes the quality of healthcare counseling. We want to become a leader of cost-effective work in maternal and child health, driving the evaluation of the full range of benefits programs like ours can provide to people. While these aims are ambitious, we're convinced they're achievable. What we need is your support and the support of this wonderful community to make this work possible. A donation of $50 provides a dozen women with genuine autonomy over their fertility, as well as greater health, well-being, and opportunity to live a truly flourishing life. Stepping back, what do these ideas mean more broadly? I think there is a platform here for a more ambitious idea of what work in global development can be, and the role effective altruism can play in it. If we want to do the most good that we can we need to consider the impact we have on people's lives as a whole, across multiple areas and across the full length of their lives. We shouldn't settle for the things that we know we can do well, but continue to aspire to improve people's lives as comprehensively as possible. Without considering the wider effects of interventions, how can we be confident that we're doing the most good? We have to keep working to get closer to measuring the direct things that people care about. Most of what we currently consider to be the most effective interventions have effects that are easy to quantify and compare. I think we should be concerned about this. Would it not be weird if the areas that are easiest to measure happen to include all the work that is most worth doing? Much of the work in global development outside of EEA prioritizes some of these less measurable outcomes, ideas of rights and choice, well-being and autonomy, without quantifying and comparing the benefits of things to work on health and income that we've measured. How can we be sure that this work isn't more impactful? That begins with measuring things more comprehensively, taking inspiration from the rich work of scholars like Sen and Nussbaum, and the expressed desires of the people who we're trying to help. Building more rigorous models that allow for this sort of comparison and evaluation is not easy, but it's something we're committed to trying to do as part of our work at the Maternal Health Initiative. I hope I have persuaded a few of you of the need and excitement of sharing this mission and evaluation work. If this is convincing, then help us make more of this work happen. Help us do the work that provides comprehensive benefits to people's lives beyond just health and income, and help us try to evaluate this work in meaningful, cross-comparable ways. If you find our work compelling, I'd love to speak to you about how it might affect your donations, work, or career decisions. Reach out to me by email, or better yet, come speak to me today in the office hours myself and Joy are holding straight after this. The opportunity to do the most good that we can is too precious to waste. Help us in our mission to transform the lives of the women we serve and inspire broader change in the world. Thank you.
Great. Not bad, eh? So we have a bunch of questions coming through on the Sopcard app. I'm going to kick off. I have a fairly tough question to start with. So let's call them ALIEs, maybe? Autonomy Adjusted Life Years.
Yeah.
How would bednets and deworming do on those as well? So I'm going to go straight to the singular.
Yeah. Oh, I think, this is the aspiration of exactly creating this sort of measure, is to have something where you can compare the benefits of, say, bednets or deworming to a program like this. I think this is hard, and so I was discussing with someone yesterday about, say, as a sort of something in this ballpark, is measuring the benefits in terms of the time that you provide to people. And so that family planning provides people with control over a very large amount of their life in terms of time, because childcare is such a large factor in people's lives. And so I think there's, say with cash, to take an easier example, you are providing people time in terms of the money that they might have otherwise needed to work to earn, and then also the additional efficiency in how much that they might earn. I think with bednets and with deworming, it becomes more complicated, but I suppose to take deworming as an example, there are similar potential flow-throughs in terms of education and therefore the autonomy that provides. And I think the excitement is to try and really tease these things out and actually have a model that might say that actually deworming is phenomenal over this as well, and we should be more bullish on deworming than we were otherwise.
If Excellent. I can jump in, I love that idea as a concept. How we'd actually do it's challenging, but one of the issues with depression is that it does take away people's sense of agency, the fact that they have any sort of control over their life and the ability to make decisions. And so that plays in kind of perfectly in the sense of helping people to realize how they can bring that back. And so I think it really does open up a whole channel of interesting sort of alternative interventions that are, again, just being overlooked.
Great. I have a very specific question about the WellBe calculation of the 1K figure. Is it dependent on spillover effects, and how much is direct benefits to the recipient of the therapy?
Yeah, we discounted for spillover. We put a little bit in, but we discounted. There was obviously some controversy around strong minds, and we didn't calculate that as highly.
Great. And then a question from Brian, which I think is very interesting, is, are there also economic and health benefits to the therapy?
Yes, there's definitely there's definitely economic, people who, if you're depressed, obviously it's difficult for you to go to work. There's a tremendous cost, not only to the person in terms of their income, it also affects people who are caring for, if you're caring for a family member, you also end up missing. So those past come in. I don't have there's not I've searched a lot. It's difficult to find, especially in the developing country context, specific amounts, but that is something over the long term I do want to look at as a way to help kind of make the case for scaling and to the national government public health system. Also, there's savings that in terms of physical health. People with depression have higher rates of heart disease, they even have higher rates of cancer. And so if we can make those economic connections, that's a case to be made to the public health system. You can save money by providing mental health care.
Great. What are some of the challenges you faced in the pilot and lessons learned to date?
I think one of the biggest challenges we faced was working with people who have significant ideas of suicidality and of suicide. And I think that wasn't initially something we had contemplated as much, but then so it's like, how do we provide that type of stepped care? Initially when I conceptualized it, was like, oh yes, we'll just refer people out to someplace else. But then reality is like the system is very, very broken, and that someplace else doesn't exist. And so now what we're looking at doing is like, how do we specialize to be able to provide that additional care for people who have that, who are in those sort of crisis situations. So yeah.
Great. And then there's a few that I'm just going to pull around as a theme. It's just a question of gender. Why the focus on women specifically?
Is that for Ben?
No, for
me.
Joy.
I don't work. We work with both men and women. I didn't state that clearly. So yeah, it's both men and women.
Great. I think it's pretty obvious with the Ben, so maybe we won't go there. Yeah. Has anybody any questions that they want to shout out? Ooh, no. Yeah.
Sorry, I missed whether the infant and maternal mortality statistics within 2 years of pregnancy, was that for a region or was that in general?
That's for, I think that's broadly across sub-Saharan Africa. And so there are variations there that can be reasonable, yeah.
Okay. Jack, last question.
I thought both your explanations were excellent, but I thought they had the hallmarks of people who probably pitch outside EA quite well. Because you used a lot of quite orthodox charitable fundraising stuff that's not that fashionable in EA, but is amazing outside it. And I wondered if that spoke to your challenges in finding EA funding, given the kind of death grip that people have on mental health.
Do you want to take that one? I mean, I suppose I'd say for us that I think there's an ideal notion maybe as well, that less that it's like highly challenging to get funding within EA, but that there is potentially some level of counterfactual benefits to an organization like ours that has obvious appeal in a broader global health and well-being context of trying to access funding that comes from outside of EA, so that our funding is not taking away from the funding from Vida Plena or from so many of the other fantastic organizations. And so I think some of the ways in which we're shaping our work, and maybe this applies for you as well, is with a long-term view to trying to get most of our funding from non-EA sources.
Great. We're going to finish there, but we're not really going to finish because we're simply going to move to the room next door. And anybody who wants to, come on inside. Jacob had 44 questions, I think, on the software app, so we might pull you in next door.
Sounds about right.
But yeah, so we're at time, and we all have other sessions and stuff, but we'll be literally in the room next door for the next hour. So thanks very much. Well done.